Thank you so much, ma'am. So now moving ahead, I'd like to invite a chairperson, Dr. Raj Nagarkar, who is MD and Chief of Surgical Oncology and Robotic Services at HCG Manavata Cancer Center, Nashik, and Dr. Dinesh Doval, sir, is a Chair Medical Oncology at Rajiv Gandhi Cancer Institute and Research Center, Delhi. So over to you, chairpersons.
Hi, good evening, everyone. Thank you, Dr. Sudeep and Dr. Shona for this wonderful opportunity and this great 7th year in review of breast cancer. In fact, for this session on panel discussion on the key abstracts in ER-positive breast cancer, we have Dr. Senthil Rajappa, who is a senior consultant medical oncologist at Indo-American Cancer Hospital and Research Center, Hyderabad. And my co-chairperson, Dr. Doval sir. We can add a few words and we start with the panel.
Welcome to all of you for this session, and this is a very important session as we're making lots of advances in the field of ER-positive breast cancers, and I think nobody more vibrant and more robust than Dr. Senthil Rajappa, who is going to conduct this panel discussion. Senthil, please, the stage is yours.
Thank you so much, sir. I wish I had a stage. So we have nearly 10 panelists. We have Dr. Tilak, Dr. Biswas, Dr. Ramesh, Dr. Shyam Agarwal, Dr. Sandeep Goyal, Dr. Ritu Jain, and Dr. Bharat, all of whom have joined. There are a couple of experts who are yet to join, so please let me know as they join. Thank you so much, Dr. Sudeep and Dr. Shona Nag, for asking me to do this panel. Let me see if I can do justice to the excellent papers that have been sent to me to be discussed. So let me start by showing you some numbers that will put the rest of the papers to be discussed today in perspective. Now, this is the benefit of adjuvant hormonal therapy. The cartoon on the top left is showing really significant differences. I put that arrow there just to show you at a glance as to what's the difference between no treatment, no hormonal treatment versus tamoxifen for 5 years, both in terms of recurrence and in terms of breast cancer mortality. You can see there's such a lot of space in between these curves. The one at the bottom, tamoxifen versus AI, there is still some space, but you see that the space is significantly smaller compared to what you're seeing on the top left of your screen. So the point is that the first jump, no treatment versus some treatment, is the highest. And then the incremental benefits that we add, they are small, they're modest, but they're certainly beneficial, and we need to choose our patients to put them through these small incremental benefits. So I have divided my panel to start with, to discuss the role of ovarian function suppression. Then we will go on to discuss who should get tamoxifen with ovarian function suppression, who should get an AI with ovarian function suppression. Then we will go on to extended hormonal therapy, and then we will do the role of CDK4/6 inhibitor in early disease. And then we will go to the metastatic setting, and then some molecular studies, and then we will finally end. Let's see how much we can do in this 45 minutes. So this is the 8-year update of the SOFT study. The study had 3 arms: tamoxifen plus ovarian function suppression, exemestane plus ovarian function suppression. This is the 8-year update that was published a couple of years ago. This is the curve that's showing disease-free survival. Now, disease-free survival includes recurrence, second invasive cancer, and death. You see that the hazard is 0.76. Now, both of these are compared to tamoxifen. That means exemestane plus ovarian function suppression and tamoxifen plus ovarian function suppression are compared to tamoxifen. You see that there is benefit in terms of recurrence-free or disease-free survival for both of these when you combine them with ovarian function suppression. The upper limit of the confidence intervals less than 1, 0.76, 0.68. Biswas, you're on my screen. So which of your patients go for ovarian function suppression, Biswas, based on this data that was published a couple of years ago?
Yeah, so if I have a pre-menopausal woman, so who is high risk, so given a choice, so my choice will be an aromatase inhibitors with OS, like EOS will be my choice.
Okay.
Other than giving a tamoxifen and the OS.
How would you define high risk, Biswas?
Yeah, so we'll have a patient in regards to tumor size, tumor grade, the number of nodes,
For example, if I ask you, a couple of examples based on the criteria that you are describing.
Right.
Would you say more than 4 nodes or 1 to 3 nodes plus age of something?
So in a premenopausal woman, so I have more than 5 centimeter tumor, more than 3 nodes, grade 3 tumors. So these will be my patients who will be considered as a high risk patient.
Okay, excellent. Dr. Ritu, would you also do something similar to what Dr. Biswas is saying?
No, I'll disagree with Ghanshyam.
Okay.
In the high risk patients, premenopausal, I would first go with the T and ovarian suppression.
You would go with T and ovarian suppression. So who gets ovarian function suppression, Dr. Ritu? Everybody who gets chemotherapy, because that was the criteria that at least they used to describe benefit in the trial, at least the results of the study that were published. So all patients who get chemotherapy should get ovarian function suppression. Is that what you're saying?
No, not all of them should.
Okay, who are they?
Especially the age of 40 years, they are not there's a perimenopausal age group.
Okay, but the trial was on premenopausal, isn't it? So all of them, so at least based on the initial results, this that I'm showing you in front on your screen is disease-free survival in patients who took chemotherapy, and that's where the benefit was in patients who did not need chemotherapy based on the investigator's discretion, did not benefit. Bharat, would you agree with do you have some specific criteria that you follow in practice, or you would say everybody who takes chemo needs ovarian function suppression?
Yeah. Sorry for my voice.
No problem, Bharat. You're as soft as always.
Thank you. So basically, as you rightly mentioned, all premenopausal women are especially at a higher risk as compared to the postmenopausal. But especially those patients who qualifies for chemotherapy, and even after the chemotherapy, they remain menstruating. That is one subset. Second thing is grade is very important. T size, even if the T size is smaller, we look at any node positive younger the patient, any node positive, higher grade of the tumor, a patient in spite of a chemotherapy remaining menstruating, these patients should get the ovarian suppression, as well as I will consider them for extended therapy also, because the recurrence doesn't stop.
We'll come to extend it a little later, Bharat. So in general, patients who continue to remain premenopausal at the end of their chemotherapy should get ovarian function suppression. That's as simple as what you can put it, right? Excellent. So let me come to this, the other data that was shown as part of this year. We come to the 12-year data very soon. I just want to show you this 8-year data so that that'll put the 12-year data in better perspective. So this is distant recurrence-free survival on the left, overall survival on the right. So exemestane plus ovarian function suppression, hazard ratio of 0.74, distant recurrence-free survival. But when it comes to overall survival, you see that exemestane plus ovarian function suppression, though had a better distant recurrence-free survival, did not translate into an overall survival. But tamoxifen, which on the left side is not statistically significant, is showing an improved overall survival on the right. This is the 8-year update. Biswas, did this data worry you that although we will say exemestane plus ovarian function suppression is what most of us would prefer doing, but that did not translate to an overall survival benefit, but tamoxifen ovarian function suppression actually translated into an overall survival benefit. 0.59 is the hazard. Biswas, did that data worry you, or you would say that this is, there's no clear explanation for what's happening, so I will stick to ovarian function suppression?
Absolutely. So there is no clear explanation. So I don't know. So how many will land up with second malignancy? So that too, I'm not.
Okay. So you're a staunch follower of exemestane plus ovarian function suppression, right? Amish, did this data, was this a concern for you? Because it was a concern for me. A lot of my patients, I decided to put them on tamoxifen plus ovarian function suppression rather than exemestane plus ovarian function suppression after seeing this. Did you do that, or this was not a concern for you? The reason why I'm asking this is, one of the explanations given for this was that with exemestane, there was a higher incidence of non-breast cancer mortality. So was this a concern for you, Amish?
So we are looking at two different aspects. I'm sure you must be covering revised STEEP criteria, where the second malignancy, they have decided that should be excluded in the analysis,
right?
So that we have a better outlook in this. So I don't think in soft 8-year follow-up, they had done that. That is one. But, based on this soft 8-year data, Senthil, how I do in my practice is in the family history of menopause, those who are 4 or 5 years away from menopause, I do 2 years of TEM and then extended letrozole for 5 years. And we have for that. That covers all the aspects of soft also, and that covers all the high-risk groups also. That is what I do in clinical practice.
Right. So you start with ovarian function suppression and tamoxifen, and then transfer your patient to exemestane over a period of time. Nitesh is, put a comment in the box saying, but isn't it because we are clubbing high and low risk? No, Nitesh, what I'm showing you on your screen is only patients who took previous chemotherapy. Of course, there might have been some patients with low risk who, by the discretion of the investigator, took chemotherapy. But what I'm showing you is as per the trial where patients actually took chemotherapy. Dr. Shyam Agarwal, did this data worry you or did it not? And did you stick on to exemestane or did you change over to tamoxifen?
I think if you look at the subgroups which benefited the most were, pre-menopausal women under the age of 35 and women who had neoadjuvant chemotherapy. So that is where the, the benefit in the subgroup analysis was there. So, I agree with Amish by and large.
Okay.
Sticking on to tamoxifen and switching on to AI subsequently.
Okay. Any reason for starting with tamoxifen and switching on to AI?
So, I think there is some benefit with tamoxifen.
Okay.
And you need to have AI for sure. There's no doubt about it.
Very good.
Then, I think it's a question of personal policy as to what you want to do.
Very good. So the data actually didn't worry us, but all of us believe that some tamoxifen to begin with, and then, shifting to AI would be the best way to go about. So this is some data that was presented at SABCS this year. This is the Ebcpcg Meta-Analysis on 4 trials, 7,000 plus patients, tamoxifen plus OFS versus exemestane plus OFS. This is showing you on the right the non-breast cancer mortality. That's 0.3% higher in the AI arm compared to the tamoxifen arm, but that was not statistically significant. So at least for me, based on what I'm seeing on my screen, the explanation for the higher mortality, at least the lack of an overall survival benefit for patients who went on OFS plus exemestane is not clearly explained, at least on the available data, at least at this point in time. So there wasn't an increase in the non-breast cancer mortality, but the bone fractures, as expected, were higher for the exemestane arm compared to the tamoxifen arm. Here we come to the 12-year update that was presented at SABCS. Now, when you look at the 12-year update, though, in terms of the absolute benefits, there seems to be some ups and downs. Tamoxifen numbers going down, exemestane actually catching up. But what I'm, a little concerned seeing is that though this is not the primary objective of this study, the primary objective or the primary endpoint was disease-free survival in the intent to treat. This had low-risk population, high-risk population, patients who took chemotherapy who did not. So what you're seeing on your screen is an exploratory analysis, and this exploratory analysis is on patients who took chemotherapy. So, I wouldn't call all of them as low risk, but, at least some of them may have been low risk. But the point is, if you see here, all these upper limits of confidence intervals going beyond one, which means that they're starting to lose their significance at least. Dr. Shyam, is that the way you would interpret these graphs, or would you say this is only an exploratory analysis? As long as the absolute benefits seem to be in the right direction, it's fine with me.
Yeah, I think I made my statement. So
okay, so you stick to that. So okay, we don't have to read too much into these graphs. Amish, would you also not read too much into these graphs and then say that it's in the right direction? So let's stick on to whatever we're doing.
It's in the right direction.
It's in the right direction. Excellent. Tilak?
I think 0.3% and just about there. I agree with both the previous ones. I probably wouldn't read too much into it. 12 years of, there are too many other variables probably.
Too many other variables, you don't want to read too much into this data, but as long as the benefits are in favor of OFS plus exemestane or tamoxifen, you're saying it's okay to go ahead and use one of them. But the reassuring thing for me based on this data is that tamoxifen has slowed down a little bit in terms of benefit, and exemestane is actually catching up. So at least that, lack of survival benefit that you saw in the 8-year is not sustained. It's kind of catching up. So that way it is, good. This is showing you tamoxifen versus an AI. So an AI, depending upon which trial it was either exemestane, letrozole, and so on and so forth. So there was no difference in terms of either recurrence, distant recurrence, or breast cancer mortality. For the recurrence, there was a difference that is statistically significant. In terms of distant recurrence, there was a statistically significant difference. In terms of mortality, there was no difference between an AI versus tamoxifen. So Biswas, you're right in your decision that if you would want to put your patient on exemestane, that is superior compared to what you get with tamoxifen, both in terms of recurrence and distant recurrence, but certainly not in terms of breast cancer mortality.
Yeah, absolutely.
This was correct. Absolutely fine. So the statement that you started with is absolutely fine. Sandeep, would this push you to use exemestane in all your patients wherever possible? Of course, you have to monitor your estrogen and all that when you're putting them on your ovarian function suppression. But would you, based on the data that I'm showing, say that exemestane is superior, so all patients who are eligible should get exemestane rather than tamoxifen?
So I think I think both the sides of the coin are correct, because somehow or the other in our mind there's still this concept that pre-menopausal tamoxifen. That's always in our mind. So even when I consider when it's pre-menopausal, I use tamoxifen plus ovarian suppression. Although the data is there, but still I don't think so. We have got to really grapple that.
Okay, so in general, the belief is that exemestane or an AI is better than tamoxifen. So let's think simple and stick on to exemestane or an AI wherever possible is what I seem to be getting as a message from all our panelists, and I do agree with that. But you should be very careful, especially in that perimenopausal age, younger women, obese women, where suppression of estrogen with your LHRH analog can be a little daisy. So please make sure that you monitor these levels, and these are actually postmenopausal based on your biochemical analysis, and not just assume that because you're using an LHRH analog, these women are likely to be postmenopausal. This is again answering the same question. It's a very crowded slide, with so many point estimates and confidence intervals that are being shown here. But what I'm trying to point out is that, as was rightly pointed out by all our panelists, wherever the risk of recurrence is high, that's based on age, that's based on T status, based on lymph nodes, which are more than 4 lymph nodes, the higher the grade. Though the confidence intervals are overlapping in all of these areas, you clearly see that the survival seems to be better, at least numerically, for patients who are taking an AI compared to patients who are taking tamoxifen. The same is what you see on the right. This is the AI versus tamoxifen question. Again, they're actually sitting nearly on top of each other, except in certain subgroups of patients. So whenever you have a higher risk of recurrence, you probably will tend to use exemestane rather than tamoxifen, along with ovarian function suppression. So that's what we get from the longer follow-up. Nitya's actually raised this point in the chat box. Is HER2 positive high risk? So Amish, here's also some data. Again, I don't think I will read too much into this data of 249 patients, where you see that tamoxifen seems to be faring better. So Amish, what would you think? HER2 is to be taken as high risk, all HER2 positive patients?
No, I think aren't we reading too much into this, Senthil?
Absolutely. That's why I said I won't give too much of credit, but I want to see what you have to say.
Senthil, I know you are a moderator and you can't be asked question, but I always like to ask you questions.
I'm more than happy to answer, Amish, if I can.
This soft text, all these, do you take in silos? Because we have 7 years versus 10 years of AI data, we have 5 years versus 7 years of data, we have early premenopausal less than 40 and more than 40 years of data, and then we have this data. So when you do a clinical practice, don't we take all the put together rather than just sticking to one slide?
Lovely, Amish. So this is the slide that you want. Okay, so this is what you call as a composite risk. As you rightly said, it's good not to take just one criteria and make your decisions. It's important to make sure that you're taking multiple criteria to make your decisions. As you rightly pointed out, on the left extreme is a patient who is extremely unlikely to benefit from ovarian function suppression. That's a patient who is nearing 50, N0, a very small tumor. All those factors listed there are good prognosis compared to the one on the right extreme of your slide, which is a very young lady with more than 4 lymph nodes, a larger tumor, a higher grade, and so on and so forth. So the point that Amish is making is absolutely valid, that you just don't go on one feature. There might be one feature here or there that's very, overarching. For example, somebody less than 35, as long as, even if it's a grade 2 tumor that's, 2.5 centimeter, you would be very tempted to use ovarian function suppression. So some of these clinical factors might be very dominant in your decision-making process, but on the whole, it's important to understand that you don't go chasing one clinical or pathological factor. It's important to put all of these together and look at a composite risk rather than look at factors in isolation. I think that's a very important point, Amish. Thank you for making that. Excellent. Now we come to the extended hormonal therapy story. So here, as always, there are 2 trial results that I'm showing on your screen. The one on the left is the Austrian trial, where patients who had 5 years of tamoxifen or an AI and 2 to 3 years versus 5 years. So roughly it's comparing about 8 years versus 10 years. On the right side, this is comparing 5 years versus 8 years, right? On the left, it's 8 years versus 10 years of extended therapy. On the right, it's 5 versus 8. 8 versus 10, you actually don't see 2 curves there at all. You actually see one sitting on top of the other. On the right side, you see that there's even an overall survival benefit of about 4% on a 4-year, on a 12-year follow-up that they're showing for this study. So let me ask Gautam. Gautam, what is your feeling based on the data that you're seeing in front of you as far as duration of extended adjuvant therapy, extended adjuvant hormonal therapy is concerned?
So I will say that usually we go for near about 8 years of extended adjuvant hormonal therapy.
Okay.
We can go up to 10 years. The benefit of extending to 10 years beyond is very, very little.
So the extending beyond 8 years seems to be very, very little. Bharat, extending how long? So I put a few choices on your screen, Bharat. Tamoxifen 10 years, tamoxifen 2 to 3 years, followed by AI 5 years, TAM 5 years, followed by AI 5 years, AI of 10 years. So what is it that you would generally do in a pre-menopausal lady, and what is it that you would do in a post-menopausal lady, Bharat? Bharat? Okay, if Bharat is not there, Tilak?
So,
Sorry.
Okay, Bharat, you can.
No, go ahead, Tilak, go ahead.
Tilak, go ahead.
Okay, right. So, again, we'll see the patient as a whole, see the other factors of the disease, and
Right.
definitely probably somewhere around 8 years would be, I did 2 to 3 years of TAM followed by 5 to 6 years of AI.
Okay.
In a postmenopausal, probably give a longer duration of AI.
Okay, so 8 years of AI in post.
Though I have prescribed 10 years of AI for high-risk patients with large nodal burden, etc.
Excellent. High-risk patients should get longer duration of therapy. Biswas, where would you fall among these 4 choices, in a pre-menopausal lady, in a post-menopausal lady? Anyway, you already said.
Yeah, so I think so 1, 2, and 3 choices we have evidence. So
Right.
AI for 10 years, at this moment, we don't have an evidence. Rather, bone health is a major issue at 10 years. So 1, 2, 3 are all these choices are viable.
Excellent. Ritu? Dr. Ritu, are you around? If not, Dr. Ritu. Yeah, go ahead, Ritu.
Yeah, I agree with Ghanshyam. First, second, third choice is my practice in the clinical practice. The 4th choice of AI for 10 years, I'm not practicing. And for postmenopausal, like the real postmenopausal, not chemo-induced postmenopausal, I practice generally for 7 to 8 years.
So
Okay.
at least good that Ritu agreed this for the first time with me.
I'm glad most of the panelists are agreeing with each other, Biswas. I think that makes my job as the moderator very easy, right? We can quickly move on as long as there are not many controversies.
Senthil,
Amish.
Senthil, you are a good moderator.
Pardon me, Amish, please go ahead, Amish.
First option of TEM for 10 years.
That's got overall survival benefit in premenopausal women, Amish.
Yeah. So TEM for 10 years, everybody would sort of agree that, they would go for TEM for 10 years.
Okay, so Dr. Shyam Agarwal, would you want to answer Amish's question? Amish is also my co-moderator today for this panel.
So sorry.
No, Amish, lovely. Nice question. Dr. Shyam Agarwal, do your patients go on tamoxifen for 10 years? There's an overall survival benefit.
Right. But you already discussed in patients who are high risk.
Okay.
Where you would like to come in with an AI, and OFS.
Okay.
So in a patient maybe who is, low risk, maybe you can think of a tamoxifen for 10.
So that 2.1 centimeter premenopausal lady N0 with grade 2 goes on tamoxifen for 10 years. Is that right, sir?
I think so.
Okay. So I think these are all gray areas. We have to sit with our patient, and depending upon our, should I say, thoughts and moods for the day, we might end up, swaying on the side of tamoxifen versus swaying on the side of an AI. There are no watertight compartments here at all. So, one always flows into the other, and that's very important to keep in mind. So I think most people seem to be preferring, starting with tamoxifen for premenopausal women. If you end up needing ovarian function suppression for that lady, ovarian function suppression plus tamoxifen or an AI seems to be preferred at this point in time, and then continue that for a period of roughly 8 years. Most people seem to be agreeing that around 8 years seem to be fine. You don't have to push to 10 years because the incremental benefits might be very small. We have answered question about what about duration in patients have an OFS plus AI. Obviously, all of us have felt that these are patients with high risk, so they should be considered for a longer duration of adjuvant hormonal therapy. This is another very interesting study. After year 5, one set of patients had intermittent hormonal therapy and the other had continuous. So Amish, does this appeal for you? Stop hormonal therapy for 3 months every year from years 6 to 9, and then the last year is fine. So would you want to do this for any of these patients?
Yes, those who are high risk for those who are India is a world capital of osteoporosis in elderly obese ladies.
Okay.
So there would be a good option there. In fact, I was going to ask about Sol, but then when you said co-moderator, so I kept quiet about that.
You can continue to co-moderate, Ramesh. I'm very happy. I'm very, very happy. As long as anybody has an interesting question, please put that
Sol study gave us the good idea about these very high-risk osteoporosis patients. It is not a bad thing to do 9 months and 3 months like that.
Amish, the other question I always keep thinking is when patients are non-compliant, we kind of, are upset with them. We tell them, if you don't take this, this will come back and so on and so forth. And then somebody publishes a trial, making compulsory non-compliance for 3 months every year. What is your thought about that, Amish?
Until informed decision is very important.
Right.
We look only at osteoporosis with AI. There are
cardiac
many side effects which Indians don't like to discuss. And if those are discussed in detail, probably many of the people at the end of 5 years would go for 9 and 3 if we give them a proper option.
Correct. I think you're making a very honest, submission, Amish, that we don't discuss many of these additional side effects with all our patients, unless patients kind of ask us. We speak to them about osteoporosis almost always, but the other things we don't. So the very important point, what you're seeing on your screen on the left side is, risk of recurrence with 5 years of hormonal therapy. What you're seeing on the right is the many anatomical and genomic prognostic factors that we will use to decide. So though all of us agree, and based on what you're seeing on the left side of your screen, that prognosis for some of these women can be really poor, but what is important also to understand is that these prognostic factors that we have listed on the right seem to be weakly predictive. You see that the risk of recurrence for some of these women can be around 50% at the end of 20 years. But if you see the incremental benefits that you get with extended hormonal therapy, it's somewhere around 2%, 4%. So not a big number, but it is a big number as far as breast cancer is concerned. And so we will very sincerely go ahead and do extended hormonal therapy for women whom we think are high risk. as was rightly pointed out, some kind of switch is what our panelists seem to be preferring, and a duration of around 8 years is what most people think is appropriate. None of us would do anywhere more than 10. 10 maybe, in a rare lady whom we think is that N 4 to 9, and you just want to push a little harder and a little longer. So this is my summary on extended. Yeah, please go ahead.
So the sole which you have shown was actually decided as a superiority trial.
Yes.
So if you go by statistics, so extended does not show that it was superior as compared to the continuous therapy.
Correct.
So continuous therapy will remain the standard of care. Yes.
It depends.
So you can't, so because as per the statistics, you can't go for the intermittent therapies.
Okay, very nice, accepted. Anyway, we're not planning to go on that unless, as Amish said, somebody is, this kind of intermittent business, some amount of, estrogen. I'm talking about testosterone, prostate cancer. There's a nice study which is talking about, occasional testosterone patients with advanced prostate cancer. There's a small study that actually is showing some benefit of doing an intervention like that. So I think that's exactly what the investigators of this trial also thought. Some restoration of estrogen levels might delay resistance to therapy is what the primary hypothesis was, but was not borne out, at least based on the study results. So here's my summary on extended AI. So on the left, the green is all the trials that were positive for, recurrence-free survival. All the reds were negative for recurrence-free survival. Remember that there's only a benefit in, disease-free survival or recurrence-free survival. There is not yet a consistent benefit as far as overall survival is concerned. We need to be cognizant of the adverse events, especially bone and cardiovascular risks. Tamoxifen to begin with and AI later, they are the group which seems to be having the best benefits. The modest benefits of patients who took AI and continued on with AI. 7 to 8 years seem to be as good as 10 years. So this is how we would, conclude our section on extended AIs. We will come to adjuvant CDK4/6. So Gautam, are you using abemaciclib in patients who would fit in the trial criteria of the Monarch study? Have you started using it?
No.
Not yet. Why haven't you started?
Not using it.
You're not using it. Why haven't you not used it, Gautam?
So the previous 2 trials comes out to be negative and a third trial comes out to be positive.
Okay.
So you actually don't know whether there is actually a benefit. The trial has shown it.
So you're worried about the lack of consistency. Is that what you're saying,
Yes.
Gautam? Okay, fine. Yes. Biswas, you must be having some patients already.
No. So I'm convinced about this data, though the other 2 trials. So we know that there are differences as a drug.
Okay.
As the selection criteria also. But my point is that, so it becomes definitely a costly affair. And second, if my patient progress, then probably I won't have an option. So at this moment,
okay, so you're keeping your cards close to your heart type. You want to use the joker later rather than use it now. No, abemaciclib is something that at least based on the study showed a benefit. Sir Shyam Agarwal, sir, the FDA approval is for patients who had a Ki-67 of 20 or more. Do you think you will strictly follow that criteria to choose patients for abemaciclib, or you would say that doesn't matter as long as they fit in cohort A of the study, which is more than or equal to 4 lymph nodes? If you got less than 4 lymph nodes, it has to be either a grade 3, 1 to 3, a tumor of 5 centimeter or more, or a Ki-67 of 20% or more. That's the group which showed the positive results. So would you say you will do a Ki-67 and decide, or would you say as long as they fit into the cohort A, they're good to go on abemaciclib?
No, I think for patients with 1 to 3 nodes and who have that borderline, who are not fitting into cohort A, so I have started asking for Ki-67.
Okay, so you're saying part of cohort A, you're going by Ki-67, but if it's 4 or more lymph nodes, you would not want to do a Ki-67. You would straight away go and put them on abemaciclib. All right, Dr. Ritu?
Currently, if I have to put a patient on abemaciclib, I will first follow what was the criteria of cohort 1.
Okay.
But my concern is the cost, and second is the toxicities.
Right. So cost and toxicity is a concern. More importantly, the financial toxicity of taking abemaciclib for 2 years is a major concern for all our patients. Dr. Preetham, I'm sorry I missed you for so long. Have you started using abemaciclib in your patients?
Not really, sir. As Dr. Ghanshyam sir said, there is a lot of confusion. One of the trials showing positivity, the other showing negativity. I think still not very much prepared for the same.
Okay, Amish, your views on Ki-67 or not to choose your patient?
First of all, before the views, the two panelists refused to believe Monarch E study. This is as good as, nivolumab in head and neck first line has failed, but pembrolizumab has succeeded. That means you should not use pembro also. Something like that. There are a lot of theoretical discussions about continuous abemaciclib versus the risk group which people had taken. And as a result, it's very difficult right now to disregard Monarch E data. I have offered in 2 patients, out of which 1 patient has already started taking, young 37-year-old female with 5 centimeter tumor. Luckily for me, Ki-67 came out to be 25%.
Okay.
Luckily for me, but even if it would have been less than 20%, with 5 centimeter tumor and 35-year-old female patient, I would have definitely offered abemaciclib to that patient.
Correct. So the graph or the table on the right side actually shows Ki-67 high versus Ki-67 low in cohort 1. You actually see that both are, from a statistical standpoint, significant, right? Whether it is the high Ki-67 or the low Ki-67. The absolute benefits are certainly higher for patients with high Ki-67, somewhere around 7.5% compared to around 3.5% for patients with low Ki-67. So if you're just seeing whether it's beneficial or not, the answer is yes. Amish, before we move on to the next one, do you think the effect will last, or do you think, that's where the Penelope story comes, after 1 year, nicely curves split, and then they came together after the drug was stopped. I'm showing you some Ki-67 data in neoadjuvant studies on the top. Till the time that the drug was taken, Ki-67 was low. The moment they stopped it, it shot up. Some reasons to think that, not certainly that it will, that the benefit may not be sustained. But if you look at the hazard ratios from the study, it's kind of stable or even slightly better over time, at least in the 2 years. What is your thought, Amish? I mean, I know.
Yeah, 19 months and 27 months, both follow-up data were consistent with each other.
Okay.
Forget about the little bit, variation in the absolute figure.
At least there was no worsening in terms of the hazard. So you at least say that it is maintained.
I want to be hopeful, Senthil, that it will remain. Now only the time would tell.
No, I think you're absolutely right, because there is plenty to be done for these women who have poor prognosis. So, you want the drug. Okay, how do we find it for our patients? Because it's very expensive. It's a different issue altogether. But at least it is there for patients who can afford it and who can take it. So, there's plenty to do in that space, and hence it will be a very valid addition as far as improving outcomes is concerned. Whether we do it or not is a different issue.
Sir.
Yes, please. Hi, Tilak, go ahead.
So, just as we discussed, adding OFS, and now we have a 12-year data which is showing like the curves going in the right direction, etc. A bit of a pharmacoeconomics into this. Why would you add a CDK4/6 inhibitor when you can offer a good OFS plus
Beautiful question,
pre-menopausal?
Interesting. So
when the curves going in the right direction.
Exactly. So you want the curves to widen further. I think that's the simple answer to the question. If you look at the Monarch study, if I'm not mistaken, just around 15 to 20% of patients in the Monarch study actually had ovarian function suppression, right? Why was it not done? Did the investigator feel it was not worthwhile doing? Is a different story altogether. It would have been much more meaningful if, a significant proportion of these patients that had ovarian function suppression, and then whether there was any interaction between patients who had, ovarian function suppression versus the benefit with abemaciclib would have been interesting. But I think this trial won't answer it. And I don't think you're going to get another big study to answer that question, Tilak. So I think these are small incremental benefits that add on is what my feeling is. You can't look at another study. It's like, R-CHOP in patients with diffuse large B lymphoma. When I was a student, R-CHOP came in and it is still not been beaten, right? So that first jump is a big jump. And then after that, all the incremental jumps that you're going to get are very, very small. I wouldn't call it a jump. It's a skip, I would say. So it's very, very difficult to do studies to answer such specific questions, Tilak. So we just need to extrapolate and hope that it will be additive rather than, one rather than the other. So that's what I would think. Okay, we just have another 5 minutes to go, so we'll quickly run through this. Dr. Shyam Agarwal, 3 studies with ribociclib showing benefit in the first line. At least one is half in the first line. The other is the Mona Lisa 7. Now you've got Mona Lisa 2. All the 3 are showing overall survival benefit. So you think that is the winner in the first line, or you think that these are cross comparisons? We shouldn't be doing it. This is not the primary endpoint of the study, and so on and so forth. Again, what's your feeling, Dr. Shyam Agarwal? What have you done to your patients ever since Mona Lisa 2 was also published or read out?
So I think all of them, to my mind, are similar.
Excellent, very good. That's a simple way of looking at it. I like it.
Right. I think we got to be practical.
Excellent.
Of course, in premenopausal, you have the maximum data with the ribociclib, but then I think by and large, at least Abima and Ribo are quite similar. So Palbo, you're getting some data saying that patients who are resistant to, the hormonal therapy, or patients who've been exposed to chemo. So there is a little, confusion going on, but then I think CDK4/6 remains CDK4/6.
Okay. Sahu, God made all CDK4/6 similar, but I think God also blessed some better compared to, the others, Sahu. That's what I would think. Anybody has a different view? Bharat, do you think we should all jump to ribociclib? Yeah, Sahu, you want to make a point, please? Or Gautam, was that you? Go ahead,
So they are similar when you are looking for a metastatic disease, but they are not similar when you are looking in the adjuvant setting.
Correct, Gautam. I think so many questions are not answered, whether the continuous dosing matters, whether the differential inhibition of the CDK4/6 actually matters or not, discontinuation rates. There are so many things people talk about, but I think you're absolutely right that we don't know the exact answer. We always try to explain whenever something goes wrong, but whether those explanations are, acceptable or not is something that is very individual, Gautam. But you have a very valid point. I totally agree with whatever you're saying. Dr. Ritu, let's ask the only lady, and then Amish, after that you. Ritu, do you like Mona Lisa?
I was not impressed with my
You're not impressed with Mona Lisa. At least the Mona Lisas that I showed on the screen were not very impressive, it looks like. Amish, you can make your point.
I
looked at it this way.
Sorry, I failed to disagree with Dr. Ritu.
You failed to disagree. Okay, you're making 2 negatives.
I'm pained to disagree with
Dr. You're pained to disagree. Okay, right.
Senthil, I look at it this way. Now,
yes,
we have the data of all the 3 CDK4, right?
Yes.
Look at the financial toxicities, because even Palbase is not an easy drug when we manage the neutropenia and everything. So I in my clinical practice, I look at 2 things: the cost, the side effects, and which drug is more comfortable with me and my patient.
For you and your patient, I think that's a very important. Amish, go ahead, Amish.
Yeah, Senthil, so Mona Lisa 3, in the first line, in addition to ribociclib, what I'm coming to the point that what Mona Lisas have taught me, and I love them, because Mona Lisa 3 upfront fulvestrant in the first line, the OS is still not, median OS is still not reached.
Right.
Mona Lisa 7 has shown OS advantage. Mona Lisa 2 has shown OS advantage. So for me, CDK4/6 inhibitor of choice right now is ribociclib. And in a metastatic setting, I love to start with fulvestrant if patient is ready to come once a month for injection.
Amish, the Percival study clearly showed that there was no difference between an AI plus fulvestrant.
There was a phase 2 study, Falcipel, and it has been chewed a lot.
But Amish, the primary objective of Mona Lisa was not to find the difference between fulvestrant and AI. So if you have to view both with the same eyes, Amish. You can't view this with subset analysis and then say, I want to do fulvestrant. We'll come to the fulvestrant story in a moment. I've got 5 minutes to go. We'll come to that at the end, and then that's the grand finale will be fulvestrant versus AI. So we'll come to that. But the point is, I mean, you are right that all of us have our own views on these drugs. Ritu was absolutely bang on when she said, comfort, cost, patients coming for their test, all these things ultimately matter, because in terms of the primary objective of all of these studies, there was absolutely no difference between these drugs. But the secondary objectives, exploratory analysis, and all these things showed that they might actually be different. And when we saw them different in the exploratory analysis, we ended up saying that these drugs are different and so on and so forth. That's where we are Let me come to Preetham. Preetham, when it comes to hormone-resistant patients, do you think abemaciclib is a preferred drug? At least that's what I hear everybody saying. And after everybody saying that, I've also changed in the second line, Preetham, that I use abemaciclib plus fulvestrant in case somebody is hormone-resistant, especially post AI. Do you choose abemaciclib or you would choose something else?
I believe that abemaciclib is a bit different drug as compared to though. I mean, because only single agent abemaciclib also does in the third and the future lines. So I think it's a bit different drug. I don't know what difference it is, but I would say in the hormone resistant patients, though fulvestrant plus abemaciclib is better.
Right, excellent. So this table is actually showing you the many differences between the trial populations and why these trials should not be cross-compared. And I think using the drug is important. It ultimately depends on how you believe on the subset analysis and decide to use one drug over the other. So that's the way I would conclude this part. And then finally, we come to this very interesting study. These are patients. Let me take 30 seconds to explain this study for people who have not gone through it. Of course, all our panelists must have gone through this. We've got 3 to 5 minutes, so that's fine. We'll do that. So this is the PADA-1 study. What this tried to do is that AI-sensitive patients who were started on AI plus palbociclib started having liquid biopsies serially, at inclusion 1 month and then 2 monthly. And when the titer of the ESR1 mutation was starting to go up, and if there was no radiological progressive disease, then these patients were randomized to AI plus palbociclib or fulvestrant plus palbociclib. The primary endpoint of this study was co-primary, safety and investigator-assessed progression-free survival. Okay, and then patients who were on AI plus palbociclib were allowed to cross over at progression to fulvestrant plus palbociclib. Very interesting. They started with more than 1,000 patients, 12,000 samples analyzed. Very difficult study to do, but I think it was very, very elegantly done. What this is showing is that if you keep doing ESR1 mutations in blood and then change to fulvestrant early, those patients have a better median progression-free survival. There's almost a doubling, 5.7 to 11.9, something very similar for Bolero-2, something very similar that we looked at Solar. All these, the same doubling with a hazard ratio of 0.63. So Amish, let me start with you. You were interested in using fulvestrant. So if you had to use it, would you follow that using blood to decide on change early will make sense? Sahu has already said his gut feeling. I thought he was going to say mid-gut feeling. Was PADA-1 will not be practice changing. No, so Sahu, maybe you have a point. Yeah, Amish.
I feel PADA-1 is a very good study.
Excellent.
Although it was 88 patients who finally received fulvestrant plus.
Because the inclusion at every point in time was so stringent, Amish.
Agreed. What I'm trying to say is that it's a good beginning.
Yes.
And it again, I am a strong proponent of fulvestrant. So
you believe in poking everybody. That's what it looks like.
For me, PADA-1 was a welcome thing.
Excellent, very good. Shyam Agarwal, sir, you are again a proponent of personalized molecular medicine, as at least I understand. So you think this is interesting and will be practice changing?
Yeah, it is interesting, and we are aware of the ESR1 data for 50 years, but none of the labs have come forth to give us that facility of doing the ESR1 testing, so which will be incorporated in your day-to-day practice.
Very good. So testing is a problem. Bharat, would you like to use this sometime? You want more data? Are you happy to get on?
Definitely, I would like to wait. Data looks promising, but again, I would like to see the PFS too after adding the after adding fulvestrant.
But you're typically making that comment that an expert at ASCO would make. The data looks promising, exciting, and so on and so forth.
I would like to wait to have an answer from you and
from me. Tilak.
Definitely thought-provoking, no doubt.
Thought-provoking. Biswas.
Interesting, but again, so we are not ready with the test and so frequent testing. So definitely we'll add on to a financial toxicity also.
Okay, Ritu, and then Sandeep.
Yeah, I'll observe closely, not currently jumping the,
Not currently jumping the gun, because if you do it later, the PFS is 3 months. So this is kind of that osimertinib curve versus the first generation follow. Everybody is starting to do that, I suppose. And then it still seems inferior to that. Sandeep, last word from you before I conclude.
Well, I think the data looks promising again, as the ASCO guys would say, but I would still not use that in my practice as of now.
Okay, so you would wait a little longer. Very good, excellent. So since we are running out of time, it's 6:50.
Senthil, just 10 seconds.
10 seconds.
Okay. Yeah, so there are 2-3 points to say that, because first thing, there's no OS benefit. Second, it's something you have to poke every 2 months or something. So
poking, you're taking blood samples.
I think
poking is not the problem. Yeah, please.
There would be patients who would having a PIK3 mutations on progression. You don't have a drug to do that also. So sequencing will be a problem if we use fulvestrant upfront on this. And last, if you look at the data for the ESR mutations, very well known that more than 50% or so patients post 6 months of AI develop ESR mutations. So that's also well documented.
So I think, Sahu, it's a question of, being more choosy versus, are you a splitter or a lumper? That's the way I would look at it. Slowly, I think all of us are moving in the direction of being a splitter rather than a lumper. But, you're not absolutely wrong in what you're saying. But as time goes by, we will get the good test. We will be able to do it. It'll be cheaper as more of us do it. And it'll also be of better standard. I think it's totally demand from the clinicians and patients that all these things will be developed in and around us. So summarizing, personalizing treatment is the key. That's the point I was making. Those with higher risk of relapse benefit from ovarian function suppression, AI over tamoxifen, abemaciclib, and external hormonal therapy. And as Amish rightly made that point, please don't go by one factor. Please look at a composite risk and then try to choose your patients for one over the other. What about CDK4/6 in the advanced disease setting? Consistent survival benefits now in hormone-sensitive and resistant cohorts. So that's something that we cannot deny anymore. It's consistent and one after the other. There's more data to suggest that these drugs may be different. So Gautam, I'm not saying they are different. They may be different. And then finally, dynamic monitoring for ESR1 mutations are at our doorstep. So it's knocking. It depends on when we want to open the door and let it in. Thank you so much, all of you. Let me thank again Dr. Sudeep and Dr. Shona for giving me this opportunity. I learned a lot. I hope you enjoyed, and all of you learned a lot, if not a lot, at least some. Thanks so much. Thanks so much.
Thank you. Awesome, Dr. Senthil.
Thanks, Amish.
Thank you. Thank you, Dr. Senthil.